Some of the different types of the artificial airway is you have the pharyngeal airways that extend only into the pharynx. And then you have the endotracheal tubes, which are placed through the mouth or nose into the trachea. Those are called endotracheal tubes. Then you have also tracheostomy tubes that go through a surgical incision through the trachea. Those are also called endotracheal tubes. But putting these things in place is referred to as intubation. In other words, we're placing a tube in somebody somewhere. It doesn't specify where, but we're placing a tube in there. All right. So if we place this tube through the mouth, it's called orotracheal. Oral meaning in the mouth, and tracheal is where it resides, in the trachea. So orotracheal intubation is when the tube is passed through the mouth on its way into the trachea. Nasotracheal, again, it's going to wind up in the trachea, but it's passed through the nose. So nasotracheal intubation is when endotracheal tube is passed through the nose first. You also have two routes for the pharyngeal airways, the nasopharyngeal airway or the oropharyngeal airway. And it depends, this is mostly about if the patient is conscious or not. Okay? If the patient is conscious, this airway, if you place it in the mouth, is going to be very disruptive to the patient. It's going to cause them to gag and spit and cough because it's going to go all the way back to the pharynx area. And so that's very uncomfortable for the conscious patient. So typically the oral pharyngeal airway is reserved for the unconscious patient. And in many cases it's also used as a bite block. We'll show you in a minute a way to place these things. But the nasopharyngeal airway is placed through the nose, okay? And it's also referred to as a trumpet. A nasal trumpet. You'll see why in a minute. Okay, but this thing is very soft and flexible, as you can imagine you'd want it to be as you put it through your nose. But it also requires lubrication, and of course for either one you have to have the right size for the individual. So here's some different pharyngeal airways. The one on the left is a nasopharyngeal airway here. All right. This is a very soft, flexible type material, and in some cases they can be cleaned and reused. Sometimes they're disposable, just depending on what you have. But you notice there's a bevel there. All right, that'll come into play in just a second. The other two are oropharyngeal airways. All right, and you see that this is going to fit over the tongue. This area right here is going to fit over the tongue in both of them. And then so the airway part comes in, that the other tip of this is open on the other side, and so you can actually breathe through that airway. Same thing with the nasal catheter. The nasopharyngeal airway here, you can actually breathe through this thing. It's about 6 minutes long. It talks about sizing and placing the pharyngeal airways, and also bag ventilation. It's about 6 minutes long.
There are several ways of correctly sizing an oropharyngeal airway. Some textbooks will recommend going from the corner of the mouth in the inverted position to the tip of the earlobe, in which case this airway would be just about the right size, maybe slightly small. Other texts will recommend looking from a profile view and making sure that it goes from the mouth to the angle of the jaw. Now when inserting an oropharyngeal airway, you want to make sure that you get a good wide mouth opening. There are several ways to open the mouth. One technique is to rest the palm of your hand on the forehead and to push with your fingers to open the mouth. If you're confident that the patient was not going to bite down on you, the cross finger technique is good. Or you can do, if there's no C-spine precaution worry, we could hyperextend the head. Any way that opens up the airway is acceptable. Now we insert the oropharyngeal airway in the inverted position, and then as we sink it into place, we rotate it 180 degrees, and then it's in place. For insertion of a nasopharyngeal airway, proper sizing is also important. Most textbooks will recommend measuring from the nose to the tip of the earlobe or the angle of the jaw. It's important that we get at least this far to bypass the tongue, which is the whole reason we use an airway. It's also important to use a proper lubricant so that we don't have to force it in place, it slides in smoothly. Now we normally use the right nair with the bevel towards the septum. Pulling back on the nostril slightly and very gently, we'll just open up the nostril a little bit. And the airway should be placed straight back with no force really. It should be very easy to slide in. If we met obstruction, we wouldn't want to force our way in.
So you see there, that's why they call it a trumpet.
If we had to use the left nostril instead, then we would turn the bevel to the septum again to avoid damaging any structures, and then we would rotate as we move in place 180 degrees. When ventilating with a bag valve mask, achieving a proper seal is paramount. If you don't have a good seal, you're never going to ventilate the patient properly. So when placing a mask onto the face, of course we put the narrow end gently over the nose. And placing the mask down, we want to keep our first 2 fingers on the mask, and then we want to take our last 3 fingers and pull the jaw upwards to the mask. So you always want to visualize and mentally know that you're pulling the jaw upwards, not forcing the mask down. If we just push the mask straight down, we'll occlude the airway just positionally. So we want to pull the jaw upwards to the mask and then gently ventilate nice and slowly over a period of at least a second, just enough to see chest rise and fall. And you're always checking to make sure that you're not losing air around the mask. But chest rise and fall is the best indicator that we're moving adequate tidal volumes. Now if you're having trouble getting a seal, or if resources permit, a 2-hand face seal is superior to a 1-hand. Very easy to pull up on the jaw and to maintain an excellent seal, and then you can have another rescuer do the ventilations, squeezing the bag. So this technique is really the preferred. If you have the resources, we strongly advocate the 2-handed technique. Now one thing that you want to make sure that you do, we mentioned the nice slow volumes. You don't want to try and bag hard and fast like this. That's a guaranteed way to force high airway pressures, and we're going to force air into the esophagus and into the stomach, and guaranteed if we keep doing that long enough, we're going to cause the patient to vomit, and then we're going to have an aspiration problem on our hands. So gentle, slow ventilations is definitely preferred. When a patient's being ventilated, one of the techniques to reduce the risk of aspiration is known as cricoid pressure. Cricoid pressure is done by applying some posterior pressure on the cricoid cartilage. Now a lot of people get this mixed up. This is the larynx, this is the laryngeal prominence, or the Adam's apple. Just below that, the next hard structure is actually the cricoid cartilage. This is where pressure is applied in order to squeeze off the esophagus and reduce the risk of aspiration. Now, the reason we do it on the cricoid cartilage is because in the neck, it's the only cartilage that forms a complete ring. All the other cartilages have an open back. They're like a C shape. And so by pushing down, even on the larynx or pushing down on any other cartilage, really won't achieve that, that pressure, that squeezing on the esophagus. So it has to be done on the cricoid cartilage itself. So some backwards pressure firmly squeezes down the esophagus and effectively reduces the risk of aspiration. So if you have the resources and you have an extra person that can apply pressure on the cricoid cartilage during ventilation, that will help reduce this risk.